Okay, well, welcome. The reason I'm going to give you a little bit of background of why I put this together or how it came together, which was that we're working on our protocols for the chiropractic side of things. We've been very busily working here to create some protocols for the chiropractic side of things. And as you know, we've obviously been the whole concept of innate choice has been born out of the literature about what is evidence-based and what is required for everybody every day for life in terms of supplementation. We're very adamant that we're not a nutraceutical company. We don't treat conditions. We're about supplying the essential nutrients that are genetically required by the human species. And certainly there's some other species that require the same nutrients, but we talk a lot about what's genetically congruent for humans. So out of that, as I was reviewing the literature, some of the stuff just was so overwhelmingly clear and unequivocal that I just decided to put this presentation together. And I know it's a bit unusual to have chiropractic included in our on the supplement side of things with innate choice, but really what we're all about, or what we should all be about, is just producing the best outcomes for our patients. And truly, what I can tell you and what I'm going to share with you today is that the gold standard of care in terms of evidence for spinal wellness and prevention and healing is chiropractic, omega-3, and vitamin D. I believe the information is so overwhelming that I believe this will become standard of practice very soon. And I would, encourage everybody to review this once it's posted up on the website as well. So, without any further ado, I think I'll just begin. We've got quite a few slides to go through here. We'll have shorter options of this available as well for people, but this one's pretty comprehensive, although I must tell you I've removed about 150 slides, so I'm getting better. Anyway, let's start. Gold standard. What gold standard means is that there's enough evidence to suggest that this should be standard of care. And I think you'll see as we go through this that it absolutely should be. So let's start with chiropractic, and this is really fun for me. I really have really enjoyed it as I've been putting these protocols together for chiropractic. It's been a great reminder, and it's been a great joy for me to go through and just understand just how solid the evidence is for chiropractic, and not only for chiropractic, but just to show that chiropractic absolutely is the most evidence-based choice available for spinal care. So anyway, chiropractic, scientific, safe, and effective. Fact, chiropractic is the safest, most evidence-based, most effective, and most cost-effective choice for spinal care. Yes, that is a fact. Not to say that we can't improve, but if you look at the options that are available out there for spinal care, there's absolutely no doubt that chiropractic is the safest and most evidence-based and most effective and cost-effective. So let's start with looking at what the choices are for people who require spinal care. Let's start with surgery. You'll see the headline: surgery is not effective, cost-effective, or safe. This is a study out of Spine in 2011. Only 26% of those who had surgery returned to work within 2 years, whereas 67% of those who did not have surgery returned to work within 2 years. So you can see there's a significant difference there. Remember, these are the people with the same issue. So surgery prevents you from getting back to work. I think we all know that, but it's nice to see it written down. 36% of surgeries resulted in significant complications. 27% of those who had surgery had to be reoperated on due to symptoms or complications. The problem is, of course, that the success rate of the reoperation is not better but worse than the initial one. So it's actually criminal what goes on, what happens to patients, and so many of them think that this is their best option, and many think it's their only option. The chances of permanent disability increase over 500% with surgery compared to no surgery. Daily opioid use, this is very significant because they're addictive and they produce all kinds of issues down the road. Daily opioid use increased 41% after surgery, and 76% of surgical patients continued opioid use after surgery. Wait till you see the data on how chiropractic reduces opioid use. It's very important. The conclusion of this study, published again in Spine in 2011. Just a reminder, Spine is the world's most highly recognized journal in terms of spinal care or spinal issues. Their conclusion is that lumbar fusion for the diagnosis of disc degeneration, disc herniation, or radiculopathy in a workers' compensation setting is associated with significant increase in disability, opiate use, prolonged work loss, and poor return to work status. So my question is, why on earth would anybody choose it, especially as their first option? Anyway, 2006, lumbar fusion outcomes in Washington State workers' compensation. Among the 1,950 eligible subjects, fusions with cages increased from 3.6% in 1996 to 58% in 2001. You're going to see these fusion with cages. I'm going to show you the actual data on that stuff and how they lied and showed there was no complications and that it was a better surgery, a better fusion surgery. I'm going to show you that study in a second. But just look at that. From 1996 to 2001, in just 5 years, the use of these cages and these surgeries increased by from 3 to 58, almost 60%. The overall disability rate at 2 years after fusion was almost 65%. Reoperation rate was 22%, and rate for other complication was 11.8%. You've got to remember, the people who didn't fall into these categories doesn't mean that surgery made them better. The fact of the matter is that the time off work, the rehabilitation exercises that people do after surgery, I mean, if you remove the surgery, these people do better. That's the take-home point. The efficacy of lumbar fusion for chronic low back pain remains controversial. Recent randomized controlled trials have shown results of fusion to be equivalent to those of structured exercise and cognitive intervention. And by the way, chiropractic is more beneficial than either of those. I suggest we put them all together, of course. Lumbar fusion rates, however, continue to increase nationally, fueled in part by introduction of new fusion devices. Remember those new fusion cages that have increased from 3 to 60% of all surgeries from 1996 to 2001. This is very interesting. This is Carnegie. By the way, Carnegie is the head of orthopedics at Stanford University. This is a critical review of a recombinant human bone morphogenic protein 2 trials. This is that cage that they use. I'll explain in a minute. The risk of adverse events associated with this type of surgery is 10 to 50 times the original estimates reported in the industry-sponsored peer-reviewed publications. The median known financial association between the authors and Medtronic, the people who came up with these cages and funded the studies to show how safe and effective they were, was found to be approximately $12 million to $16 million. That's not how much it cost for the study. That's how much the authors of the study got. Another study with Carnegie, this is now in the Spine Journal. This is a phenomenal review of all the possible interventions for spinal care. It's in the Spine Journal 2008, Volume 8. You should get a copy of that. It's incredible. Anyway, this is Carnegie again, head of orthopedics at Stanford University. Lumbar fusion for common degenerative changes appears to offer limited relative benefits, if any, over intensive non-operative management. That's us, non-operative. There is no convincing evidence to support the use of dynamic stabilization devices in the management of chronic low back pain. Same study. There are still no clearly defined clinical practice guidelines related to surgical intervention for chronic low back pain in the absence of serious structural disease such as instability from trauma, infection, or neoplasm cancer. Unless you have instability, infection of cancer, you should not have surgery. And this is from the head of orthopedics at Stanford University. He goes on to say, not surprisingly, this lack of consensus has led to huge geographical variations in the use of surgery for low back pain across the United States. In other words, wherever they have better coverage for it, you get more surgeries. In addition to uncertainty regarding the efficacy of surgery for chronic low back pain, there's no evidence. It should also be noted that the potential harms and costs associated with these interventions are substantial. Are they ever? So I just think it's really important, because really what we have to talk about is we have to talk about what options are available to a patient. It's not just the old game that says chiropractic has to prove beyond any reasonable doubt, you know, that we're meet this gold standard of care and gold standard of evidence that no other intervention for the spine meets. It's what's the most evidence-based, what's the best choice available to any patient. That's why I love this evidence-based movement, this evidence-informed and evidence-based movement, because for the first time in history, we have a level playing field. The microscope is now on all interventions equally, rather than living with this presupposition that everything that's done from medicine or physiotherapy is evidence-based and everyone else has to somehow prove that they live up to this gold standard, which never existed. So the greatest thing that's ever happened to chiropractic ever is that there's now this evidence-based movement that means that now it's which of the available interventions is most evidence-based. And you'll see that we just come out on top. So let's look at drugs. Again, this is in the Spine Journal 2008, Volume 8. A recent review found 59% of patients treated with opioids for less than 3 months experienced an adverse effect. Adverse effects were even more common with treatment longer than 3 months, occurring in 73 to 90% of patients, and up to 1/3 of patients had to discontinue treatment because of side effects. Constipation occurs as a result of decreased peristaltic propulsive contractions, meaning it messes up your parasympathetic nervous system. Increased small and large bowel tone and decreased biliary, pancreatic, and intestinal secretions. And remember, these are what you have to live with in order to get numbed. It's not like these opioids fix your spine, produce more range of motion, give you more stability, give you better neurology. These things, the best outcome possible is to be numbed, and these are the adverse effects that you have to live with, and they don't even work to numb people 60% of the time. Clinically, the most common problems in men who take opioids are low libido, erectile difficulties, low energy, easy fatigue, and depressed mood. No problem. They have drugs for all of those things as well. This is a sickening cascade that occurs in these people who are told that they should take a drug to fix a problem in their spine. That's like a dentist telling people to take opioids instead of having their tooth fixed. It's repugnant, in my opinion. In women, there may also be decreased libido and changes in menstrual cycle. Imagine what must be happening to their neurohormonal system if they're getting these kind of changes in their cellular function, people. It's incredible. There may also be instances of osteoporosis and broader hypothalamic pituitary suppression. Sedation and drowsiness are the most common CNS adverse effects of opioid therapy, though a wide range of other neurological symptoms may occur, including confusion, hallucinations, nightmares, myoclonus, and dysphoria. How could they possibly be recommending this as a sane, evidence-based approach for people with low back pain? And remember, the best possible outcome is numbing. It should be noted that the withdrawal rates reported in randomized controlled trials of opioids were generally high because of side effects. Among the remaining patients who were able to tolerate opioids, 1/3 are excellent responders, meaning they got numbed. 1/3 are fair responders, meaning they barely got numbed. And 1/3 don't respond at all, meaning they didn't get any numbing, but they had to deal with all the adverse effects. So if you think if there's a 40% withdrawal rate from studies because of adverse effects, and a remaining 2/3 receive little or no relief, meaning the relief is only numbing, it's all these side effects for the temporary pain relief in 20% of patients. Let's look at evidence-informed management of chronic low back pain with non-steroidal anti-inflammatory drugs, muscle relaxants, and analgesics. Again, this is in the Spine Journal, Volume 8, 2008. Studies did not provide evidence for long-term use of muscle relaxants in chronic low back pain. But listen, if you can only use them short-term, it's not going to do you much good if you have a chronic issue. Muscle relaxants demonstrated more central nervous system side effects compared with placebo in all trials. Sudden discontinued chronic use of benzodiazepines is associated with delirium tremens, whereas abruptly discontinuing baclofen may result in seizures. This is what happens when you stop taking these drugs. And remember, why were you taking them? Because you were attempting to be numbed. Not to fix the problem, but to be numbed. The risk of GI, renal, and hepatic or liver complications in patients taking non-selective NSAIDs is well known. The cost of side effects associated with these drugs should also be considered. A Canadian study using the Quebec Provincial Public Healthcare Database found that for each dollar spent on non-selective NSAIDs, an extra 66 cents was used on their side effects. And how did they deal with their side effects, ladies and gentlemen? With more drugs that had side effects. Why? Because it's all they have. They have no other options to offer patients. Drugs, surgery, or referral for physiotherapy. That's the only options they have. Of course, they could refer to a chiropractor. We hope. Again, that's a very quick review of the data on drugs and surgery. There's much more available. They just don't work, and they're not safe, and they're not effective, and they're not evidence-based. Manga report. This was an independent report commissioned and paid for by the government. None of the authors or contributors were chiropractors. The head researcher, Pran Manga, PhD, professor and director, Masters in Health Administration Program, University of Ottawa, and his co-authors did an exhaustive review of all the available literature. Their conclusions are, on the evidence, particularly the most scientifically valid clinical studies, spinal manipulation applied by chiropractors is shown to be more effective than alternative treatments for low back pain. Why did they just put low back pain? Because it's the only thing they looked at. Many medical therapies are of questionable validity or are clearly inadequate. Our reading of the literature suggests that chiropractic manipulation is safer than medical management of low back pain. Of course it is. What the literature revealed to us is the much greater need for clinical evidence of the validity of medical management of low back pain. Indeed, several existing medical therapies for low back pain are generally contraindicated on the basis of existing trials. There's also some evidence in the literature to suggest that spinal manipulations are less safe and less effective when performed by non-chiropractic professionals. They go on to say, there is an overwhelming body of evidence indicating that chiropractic management of low back pain is more cost-effective than medical management. The lack of any convincing argument or evidence to the contrary must be noted and is significant to us in forming our conclusions and recommendations. The evidence includes studies showing lower chiropractic costs for the same diagnosis and episodic need for care. Not only do we work better, we're actually less expensive. In our view, says Manga, the constellation of the evidence of the effectiveness and cost-effectiveness of chiropractic management, the untested, questionable, or harmful nature of many current medical therapies, the economic efficiency of chiropractic care, the safety of chiropractic care, and the higher satisfaction levels expressed by patients of chiropractors. Together, this evidence offers an overwhelming case in favor of much greater use of chiropractic services. What was the response of the government to this report? To actually cut any funding for chiropractic. By the way, the Ontario government is now bankrupt because of healthcare costs, sickness care costs. A comparative analysis of individuals with and without chiropractic coverage. This is out of the Archives on Internal Medicine 2004. In our study population of 700,000 or 0.7 million members who had chiropractic coverage in the medical plan, we estimate an annual reduction of approximately $16 million as a result of lower utilization of higher cost items. The people who got chiropractic care had spent less money in the system. This study provides additional information regarding the economic benefits and utilization patterns associated with systematic access to chiropractic care. Systematic access to managed chiropractic care not only may prove to be clinically beneficial, but may reduce overall healthcare costs. The increasing acceptance of chiropractic care as a source of comprehensive complementary care for neuromusculoskeletal problems is reflected in that the chiropractic field is the fastest growing among all doctoral level health professions. Again, let's compare what we have to offer to what medicine has to offer. Drugs, surgery, or referral. That's the only options they have, none of which have any evidence. Clinical and cost outcomes of an integrated medicine IPA. This is in JMPT in 2003. In the limited population studies, PCPs utilizing chiropractors emphasizing a variety of CAM therapies had substantially improved clinical outcomes and cost offsets compared with PCPs utilizing conventional medicine alone. A follow-up on this study in 2007. Chiropractors using non-surgical, non-pharmaceutical approach demonstrated reductions of both clinical and cost utilization when compared with PCPs using conventional medicine. We work better and we cost less. Mandated health insurance coverage for chiropractic treatment and economic arrangements with implications for the Commonwealth of Virginia. Dr. Schifrin, who is both an economist and a clinical professor of preventive medicine, evaluated mandated health insurance coverage for chiropractic treatment. His conclusion was, a fair interpretation of the evidence accumulated to date indicates that the impact of chiropractic mandates comes close to the best case scenario of low costs and high benefits. Another study, 1996. Analysis of claims over a one-year period in a Louisiana HMO in which patients were permitted direct access to either a primary care gatekeeper physician, meaning medical doctor, or a participating chiropractor for back and neck pain. Chiropractic care was substantially more cost-effective. Let's look at a comparison. This is Cifuentes in 2011, published in the Journal of Occupational Environmental Medicine. If you don't have the study, get it. They compared chiropractic to physiotherapy and medical care. Care from chiropractors during the disability episode, during the health maintenance care period, and the combination of both was associated with lower disability recurrence hazard ratios, meaning our patients stayed healthy much more than the other two options. In addition, people who were mostly treated by chiropractors had, on average, less expensive medical services and shorter initial periods of disability than cases treated by physiotherapists and medical physicians. Those cases treated by chiropractors had less use of opioids and fewer surgeries than those treated by physiotherapists or medical doctors. This clear trend deserves some attention. This is one of the most important statements I've ever read. It's incredible. This clear trend deserves some attention considering that chiropractors are the only group of providers who explicitly state that they have an effective treatment approach to maintain health. Why? Because we're about function, not just symptoms. And people are starting to recognize it. And you know, I'm not sure if we recognize it well enough. Bonfortnell, 2008. The literature, this is in that Spine journal, the large review of all available options for spinal care. The literature provides evidence for several conclusions regarding spinal manipulation for chronic low back pain. There is also evidence that spinal manipulation is superior to usual medical care for patient improvement. Spinal manipulation is superior to surgery, medication, and acupuncture for pain and disability reduction. Again, Carnegie, 2005. Again, he's the head of orthopedics at Stanford. The patient should understand that the primary goal of treatment is to maximize function and that some ongoing or recurrent back pain is likely but not dangerous. Accommodation should be made to resume work as soon as possible, even at a low level. In the absence of severe, pardon the typo, in the absence of severe spinal disease or radiculopathy, surgery should be avoided. I took the slides out, but I want you to know that in that, if you look at that review or look at some of the other stuff that we'll be talking about in terms of our protocols, is that they did a thorough review in the Spine Journal 2008 and looked at all of they looked at TENS, ultrasound, acupuncture, massage, interferential current, laser, and distraction, the lumbar distraction tables, and they found there was no evidence for any of it. None, zero evidence, not even a single study for TENS, IFC, interferential current TENS, ultrasound, and I forget one more that's so commonly utilized in physiotherapy offices. Not a shred of evidence. It's actually incredible when you start to compare if instead of comparing chiropractic to a gold standard that doesn't exist, if you compare chiropractic to all the other alternatives, there's no close second. We're clearly the most evidence-based intervention possible, and we're the only ones who talk about function and maintaining health instead of just trying to numb people and get away from symptoms. One of the most important things people need to understand is that restoring spinal health takes time. The pain data from the randomized trials did not support claims of restricting chiropractic care to 6 to 12 visits for headaches, neck pain, cervical brachial pain, or upper back pain. In fact, assuming a constant linear dosage response, the data indicated a minimum of 24 visits on average would be needed to document, resolve, and stabilize these conditions. These people are coming up telling people that they should have 3 to 5 visits. By the way, not only does that not give you time to restore function and to maintain it, but the problem with those studies is that those studies do not take people to the point of total recovery. What they do is they have a pain study and they say, well, let's treat people for 12 visits or 16 visits or 7 visits. And if there's a significant improvement from baseline or from when they started, they'll say, well, chiropractic had a significantly positive effect because they have less pain according to the visual analog scale. However, you cannot extrapolate frequency and duration of care data from those studies because it's totally invalid, because those studies do not take people to the point of total recovery. So you can't get any information about frequency and duration of care from studies that have a set period of intervention from the start, and they only assess whether or not pain has been reduced. They don't assess how long it takes to get people actually recovered. And they make a very good point of that in this study. This is a really interesting study out of 2011. Does maintained spinal manipulation therapy for chronic nonspecific low back pain result in better long-term outcomes? Published in Spine, again, the world's best journal in terms of the spine. 60 patients with chronic nonspecific low back pain lasting at least 6 months were randomized to receive either 12 treatments of sham SMT or placebo for a month, 12 treatments consisting of actual care for a month but no treatments for the subsequent 9 months after that, and 12 treatments over a 1-month period, along with maintenance spinal manipulation every 2 weeks for the following 9 months. So the three groups were a sham or placebo group, a group that got care for 1 month, and a group that got care for 1 month and then every 2 weeks for the next 9 months. Look at the difference in results here. To determine any difference among these therapies, we measured pain and disability scores, generic health status, and back-specific patient satisfaction at baseline, 1, 4, 7, and 10-month intervals. Listen carefully. Patients in the second and third groups experienced significantly lower pain and disability scores than the first group at the end of 1 month. So after 1 month, the sham group didn't get better. Both groups that got care during that month got better. Great. Let's look at this though. However, only the third group that was provided spinal manipulations during the follow-up period, meaning every 2 weeks for the next 9 months, showed more improvement in pain and disability scores at the 10-month evaluation. This is really significant. Listen. In the non-maintained SMT group, in other words, the group that had a significant improvement after 1 month but then had no more care, the mean pain and disability scores in that group returned back to their pre-treatment level. Not only did they not continue to improve like the group that got regular care did, but they actually went back to their pre-treatment level, meaning that month of care that they paid for was a waste because they didn't continue to come in and get care. I can't hear you, but I know you're saying, wow. Let's look now. So again, what is the gold standard in terms of interventions? Surgery, drugs, physiotherapy, or chiropractic? It's clear that the gold standard is chiropractic, but there are some other gold standard. There are some other things that should absolutely be standard of care for everybody who comes into any office. And in fact, well, you'll see. You'll see. So let's look at the omega-3s. Omega-3 fatty acids are essential nutrients and thus a human genetic requirement for healing and prevention. You shouldn't, in other words, it's not just people who have a spinal issue that require omega-3 fatty acids. Essential nutrients mean that these have biological activity that every cell requires in order to function properly. So just because they have a therapeutic effect doesn't mean that they're a therapy. It just means that the people who are deficient in them end up becoming symptomatic often, not always, but often. But the truth is that these nutrients are required by everybody every day for life. So I don't want to give you the message that these nutrients should only be prescribed for people who have back pain. What I'm letting you know is that the people who are deficient of these will just not heal the same and are at a much higher level of predisposition to have spinal pain and spinal issues, less spinal function. Here's a study out of Surgical Neurology 2006. The agent best documented by hundreds of references in the literature for its anti-inflammatory effects is omega-3 essential fatty acids found in fish and in pharmaceutical-grade fish oil supplements. Listen to me carefully now. It's not the fact that it has an anti-inflammatory effect. It only has an anti-inflammatory effect if you're pro-inflamed because you're deficient in omega-3 fatty acids or pro-inflamed from a bad diet. But the fact of the matter is, you can't properly control the inflammatory process if you're deficient in omega-3 fatty acids. The active ingredients in polyunsaturated essential fatty acids are EPA and DHA. I'm sure most of you are familiar with that. There is extensive documentation in the rheumatology, ophthalmology, and cardiovascular literature on the beneficial anti-inflammatory effects of fish oil in the reduction of joint pain from rheumatoid and osteoarthritis, improvement in dry eyes and macular degeneration, and also major positive effects on coronary atherosclerosis, which is now considered an inflammatory disease. In an editorial published in the same issue of Surgical Neurology, J.I. Osman, MD, PhD, states, the importance of this work to neurosurgeons is that now there is an analgesic agent that can take the place of the COX-2 inhibitors and be used with no side effects. In other words, COX-2 inhibitors are a disaster, but the reason people are so pro-inflamed is because they're deficient in the omega-3 fatty acids and so toxic with the omega-6s. And omega-6s drive that prostaglandin pathway. Another study out of the journal Pain in 2007, 33% of those who use complementary medicine cite pain as the primary reason. Why? What is pain? Pain is the great motivator. Pain is the way that your body says to you, you are not listening and you are killing us, so I'm going to put you in pain to motivate you to change your lifestyle choice. That's what pain is. It's a motivator of behavior. The last thing we should do is try to remove it without addressing the cause. If pain goes away from addressing the cause, you have a perfect outcome. If pain goes away because you've blocked the signal of pain to motivate that behavior and lifestyle change, you've done a disservice to that patient and they're sicker but more comfortable. There's a considerable difference between those two outcomes, and that's why chiropractic is so ideal, because our paradigm has always been to address the cause. With one exception, there is little in the way of empirical evidence to support the safe and effective use of dietary supplements for managing pain. By the way, there's two exceptions in the literature now. Since 2007, the amount of information on vitamin D is overwhelming, which is why I did not include vitamin D as part of our essential nutrient system to start. I just didn't feel the evidence was there. But the amount of evidence has been so overwhelming that it's forced me to add another product to our essential nutrient system, which I did kicking and screaming because I don't like people having to take supplements. I like the fact that they get it from their diet. But the evidence for vitamin D is just too overwhelming, which you'll see in a minute. The exception is the omega-3 polyunsaturated fatty acids. Controlled trials demonstrate their efficacy in reducing joint pain associated with inflammatory conditions, including rheumatoid arthritis, inflammatory bowel disease, and dysmenorrhea. And again, why are those things inflamed? Because they're deficient in omega-3s, and they have pro-inflammatory diets, and they don't exercise properly, and they're stressed out. You know, you get it. A meta-analysis of 16 studies at 3 to 4 months showed significant effects of 4 of 6 pain outcomes: patient-assessed pain, morning stiffness, number of painful and or tender joints, and NSAID consumption. They actually reduced the amount of drugs. And all of these studies, you should know, were randomized controlled trial, placebo-controlled clinical trials. Previous reports suggest that the therapeutic benefits of omega-3 polyunsaturated fatty acids are usually manifest after approximately 3 months. It takes time to become sufficient in omega-3 fatty acids. The great news is there's some really important side effects that come along with taking sufficient amounts of omega-3 fatty acids, and those are that you have less chance of cancer, heart disease, your brain works better, you have better moods, you have less chance of virtually every chronic illness, and you're going to live a longer, healthier life. We hypothesized that patients taking omega-3 fatty acids for 2 months or less would not benefit significantly for pain reduction. Your cells immediately start to work better, but it does take time for your, because of your metabolic rate. You can't mega dose with anything and think that that's going to be taken into your system quickly. You don't speed up your metabolic rate of implementing these omega-3 fatty acids into your cell membranes just because you take more of it each day in consumption. You can't do that with anything. Megadosing doesn't make sense because you don't change the metabolic rate of the human being by megadosing. The fact of the matter is, you might be able to get it into the fat cells and have it there to utilize later, but the reality is that the idea of providing properly normal amounts on a daily basis that people actually can metabolize and ingest and absorb and utilize is the only way to go about it. That's why everything takes time. There are no quick fixes, folks, especially when you're dealing with chronic health. Chronic health comes from chronic behavior choices, obviously. Let's quickly look at vitamin D. Vitamin D, again, is an essential nutrient, and that's a human genetic requirement. Vitamin D is actually, you could call it a hormone. Many people do. I think that's probably more accurate. The reality is it's not normally produced by consumption. It's actually produced by consumption of saturated fats, which provide you the ability to create cholesterol, and it's cholesterol that's converted by the sun to provide you with vitamin D. If you actually look at some of the horrible effects of people taking cholesterol lowering medications, you'll find out that if you lower your cholesterol levels, you have no ability to convert sunlight into vitamin D. So the reason that we need to take vitamin D directly is because we're not getting enough exposure to sunlight. And unless you're doing that without sunscreen on and in the sun in a way that you need about half an hour a day in the exposure to sunlight, that the sun's high enough above you that your shadow is not longer than your body. So not very many humans get that anymore. And that's why the people that moved away from the equator, as humans have moved away from the equator, you can see that they started eating more and more organ meats because they had to find a way to get enough vitamin D in their diet because they weren't getting enough from sunlight. And that includes almost everybody in the industrial world now. Vitamin deficiency and chronic inflammation. The active form of vitamin D is a potent modulator of inflammation and may play a role in shutting off chronic inflammatory responses. Yes, you need to be sufficient in vitamin D in order to properly run your immune system and your inflammatory system. Subjects were treated for 3 months with 5,000 IUs a day to 10,000 IUs a day of vitamin D. What they did was the heavier the patient, the more vitamin D they got. They made it based on body weight. There were no episodes of hypercalcemia reported, and pain symptoms relieved in 95% of the patients. That's for people with chronic low back pain, by the way. Another study out of Pain Treatment Topics, June 2008. Vitamin D, a neglected analgesic for chronic musculoskeletal pain. We don't want to use anything as an analgesic. We don't want to numb people. We want people to feel better as we address the cause of why they're not feeling well. A big difference. Many patients with vitamin D deficiency may complain of dull, persistent, generalized musculoskeletal aches, pain, and weaknesses. Actually, what they're getting is actually a mild form of well, I don't want to give it away, but I'll show you here. You'll see it. It's kind of neat. Continuing with the same study. Experts recommend that vitamin D deficiency should be considered in the differential diagnosis of all patients with chronic musculoskeletal pain, muscle weakness or fatigue, fibromyalgia, or chronic fatigue syndrome. One of the great things that you should do with these garbage can diagnoses of fibromyalgia or chronic fatigue is just tap on their sternum with your finger, and you'll find, regardless of all the other spots that show tenderness, of course they're chronically inflamed, and there's all kinds of other issues going on with these people. But if you tap on their sternum, which is a bone very close to the skin, you're going to find it's very, very tender, and you're going to see why in a minute. Some researchers have found that this vitamin D deficiency to occur in up to 85% of chronic musculoskeletal pain cases, especially those involving the lower back. Another study out of Archives Internal Medicine 2008. A group of type 2 diabetic subjects with chronic painful neuropathy were supplemented with 2,000 IUs of vitamin D a day for 3 months. Symptoms improved an average from an average of distressing to an average of mild. Overall results were a nearly 50% reduction in pain scores. And by the way, that's still not enough vitamin D. They should be at 5,000 IUs a day. And look at the results. One investigation in patients with fibromyalgia syndrome found that pain symptoms, depression, and anxiety were strongly associated with insufficient vitamin D, which is exactly why you should never wait for people to have symptoms before you're recommending essential nutrient supplementation. Because its actions address underlying processes, vitamin D supplementation may take months to facilitate pain relief, which can range from partial to complete. By the way, we also are posting up PowerPoint presentations just on vitamin D and omega-3s as well. So they go into more detail of this, although I'm sure most of you find this is enough. But there is more detail there if you want, and those things will be posted up on the website. Every single one of not only your patients, but their family members and your family members and people in your community require a chiropractor, omega-3 fatty acids, and vitamin D. And the omega-3 and vitamin D has to be every day for everybody for life. It's not maybe. It's for sure. What are the daily requirements? Experts recommend 3,000 to 4,000 IUs per day as necessary to create sufficiency There's a lot of evidence to say that should be probably 5,000 IUs a day, which is what we recommend. We don't put that on the label because we're not allowed to, but that's really what you should be looking at. So again, I'll have a longer version of this available as well for you or anybody else who wants to look at it, going into more detail. But I think, I mean, even with that, you know, if it's every single one of your patients, it should be part of your protocol, that when they come in, not only do they get adjusted, but you make sure that they're sufficient in omega-3s and also the vitamin D. You're just never going to get the same clinical results. You're never going to get the same changes in comfort. You're never going to be addressing the causes of their issues, because the fact of the matter is, without vitamin D, they're going to have mild form osteomalacia. There's no question about it. Amongst the fact that, in addition to that, with vitamin D, I mean, they're now saying up to 75% of cancers are based on vitamin D deficiency. You can't run your immune system, especially your cell-mediated immune system, which is the thing that protects you from the flu. I invite all of you to go and review the article I wrote on vitamin D and the flu. I'm sure that's posted up. If it's not, I'll make sure it is. So the reason why vitamin D actually works better than the flu vaccine, of course, obviously, what wouldn't? But the reason it does that is because the seasonal flu is based on, your protection from the flu is based on your innate immune system, not your antibody immune system. So, you know, think about it. The flu virus changes, as does the cold virus, so rapidly that it's not that you produce antibodies to the flu. You don't do that because it would never protect you, because the flu is different every year. The part of your immune system that protects you from the flu is your innate immune system, because it actually attacks those pathogens and destroys them when you get exposed to them. It's not that you use your antibodies from the previous year to protect you from the flu, which is exactly why they change the flu vaccine every year, which doesn't make any sense. You can't produce it's not your antibody system that protects you from the flu. So what runs your cell-mediated immune system, and what properly controls inflammation, and what does your cell-mediated immune system, what do they have receptors for? Well, they have receptors for vitamin D, and when you compare the people who have adequate amounts of vitamin D over the winter months, you'll find that the flu reduction is it's incredible, actually. So go and look at that stuff. It's important. But again, people don't just need vitamin D or omega-3s, you know, during flu season. These are essential nutrients that people require every day for life. Not only will it prevent pain, but when people are in pain, one of the main causes is for sure going to be a deficiency in these things. So I hope that's helpful. I'm happy to receive some emails at info@innatechoice.com if you have any questions. I encourage you to to review this with your staff and to look at the longer version as well. And again, I mean, we're really thrilled that we had 500 people for this, and I really hope the people from Australia that had the power issue got on, and I just appreciate many of you got up early. Many of you are, I know, rearranged your schedule for this, but the difference that you're going to see in your office when you start to implement this as part of your protocols, it's not optional, as part of your protocols, we're just going to make a huge difference. So again, thank you, and we'll do another webinar next month, so we'll keep you posted. Thank you very much.